Hello, everybody, and welcome to the Savana COVID webinars. It's a pleasure to be here. I hope you are safe. And I want to introduce myself. I am Ignacio Medrano. I'm a clinical neurologist and the Chief Medical Officer at Savana. And it's a pleasure today to have with me speaking Dr. Joan Soriano. He is a medical epidemiologist and he's working at the pneumology department at Hospital Universitario de la Princesa in Madrid, Spain. He's also an associate professor of medicine at the University Autónoma de Madrid. He's a researcher with a long and extensive and impactful career in COPD, tobacco, and other chronic respiratory diseases. I would like to remark that he's one of the top researchers, clinical researchers that we have in Spain and in Europe regarding pneumology. Thank you, Joan, for being with us, and I will let you to present now.
Thank you, Dr. Medrano. Thank you, Nacho. Let me just get the remote here. If I can get control with the slides, and while I receive some help, I would like to say that this is a pleasure to participate in this webinar. And excellent, thank you. Before I start, these are my conflicts of interest, my disclosures. I declare I have no real or perceived conflicts of interest that relate to this presentation. I would like to start with one of my favorite books from one of my favorite authors. This is Gabriel García Márquez, the Colombian Nobel Prize awardee of literature. And in this book, Love in the Time of Cholera, he's talking about malaria, he's talking about cholera, and he's talking about love. And it is a very recommendable reading, especially in times of an outbreak. And the main character, Florentino Ariza, actually at the end of a long time, he says that washing his hands and persistence gets the love of Fermina, the female character. I borrowed the title for this comment in the European Journal of Epidemiology about humanistic epidemiology, because like many of you that are listening and watching, you have suffered tremendously this outbreak. And for instance, this is a photo published in this comment in the European Journal of Epidemiology of the day when auxiliary nurses and some young residents in Hospital de la Princesa got their space suits. During the first 2 weeks of the epidemic in Madrid, most of us and most of them, they were just working without proper protection. So they were just like a football team in the photograph, just so happy that they were finally protecting themselves and protecting the patients that they were taking care. If you go to PubMed, you see that there is an avalanche of publications. And this was a search conducted last Sunday, when you can see in here that there were more than 19,000 papers. But I just did this 1 hour ago, and just 2 days later, there are almost 21,000 papers if you combine the terms COVID-19 and SARS-CoV-2 virus. And it all started with the New Year's Eve comment from the WHO that there was a cluster of unidentified bilateral pneumonia in Wuhan, China. And this was the first paper in PubMed, the comment in Science by Cohen and Normile. But after this, there have been these more than 20,000 papers on this new disease. And we should say that many things are new, but still many things we don't know. Also, authoritative voices like the one of Professor Nick White. He's a well-established and seasoned epidemiologist that has a chair of epidemiology in the University of Bangkok and also in Oxford University. He was saying that unfortunately, the level of scientific articles on COVID-19 has been disappointing, especially with the Lancet gate, the problem that occurred last week with the retraction both in the Lancet and in the New England Journal of Medicine of publications involving this enterprise, Surgisphere, that basically it appears that they fabricated data. And this is a disreputation for not only the field of medicine and journals, but for also for researchers. So there are more than 20,000 papers. I would like to talk about one more. And one is that one that with Dr. Izquierdo and Dr. Ancochea, and also with the friends here of Savana, that we just have this preprint in medical archives, and that during the next minutes, I would like to dissect. And especially if some of you in the UK or in Austria or elsewhere, eventually you are invited to peer review this paper, please be kind with us, because we would like that this is not only a preprint, but also that this is accepted in a peer-reviewed journal. So the style here in Savana is to start with the end, to start with the conclusions. And basically, during the next minutes, I'll talk about a population of 10,504 patients with COVID-19 that we did research using the text of the electronic health records, and we identified 3 baseline characteristics that identify the individuals that will be admitted in an intensive care unit. And these results, it was concluded that an age above 56 years old, a fever of 39 Celsius or higher, or tachypnea, that is 20 or more breaths per minute, were associated with being admitted in the intensive care unit. For this, it was used the electronic health records of more than 1 million patients from the region of Castilla-La Mancha in the southeast of the center of Spain. And we were reusing all clinical evidence generated by physicians, both in primary care and in hospital care in this autonomous community of Spain. So what I would like to do in the next minutes is to talk to you about this general population study using big data tools and to try to identify what was the natural history of this outbreak in terms of symptoms and in terms of testing, especially because the data that we were analyzing started in the 1st of January 2020, and it was cut in the 31st of March of 2020. So it's 3 months of data, and at least in the first weeks of the pandemic, here in Spain, we didn't have the serological test. So basically, we had to rely on the diagnosis of COVID-19 by a clinical condition only. For this, we will show subgroups of patients like confirmed positives, confirmed negatives, and also the possible cases just based on the report from imaging and the symptoms that were identified by the doctors in the clinical notes. And as I said, this first real-world evidence on COVID in Spain comes from Castilla-La Mancha. Castilla-La Mancha, here in the map, in the center of Spain, you have Madrid. This orange dot is made of 5 provinces: Toledo, Cuenca, Guadalajara, Ciudad Real, and Albacete. And for this, the total population is about 2 million individuals. Well, during this 3-month period, Savana was able to collect electronic health records for at least one medical contact of 1.3 million individuals. And the SESCAM system of health in this autonomous community, it was a first cut conducted in April 2020 with an intermediate report, and we will conduct this month a final report with phase 1. Eventually, there will be a second phase in which we will integrate this data of this autonomous community with other regions in Spain and also some international data collected in Europe, the US, and hopefully also Canada. So let me just show you the strobe flowchart of participation of these individuals. As I said, the beauty of this analysis is that in the entire region, the entire autonomous community of Castilla-La Mancha, they all use the same electronic health records that intervenes in between primary care and the hospital, and also that this is weekly available for the researchers in Savana. So from the total population of more than 2 million people, during these 3 months, there were medical contacts of 1.3 million. And out of these, it could be identified that during the first 3 months of this year, there was a total population of 10,504 individuals with this new disease, COVID-19. In the end, of these individuals that were diagnosed with the disease, 6% were admitted in an intensive care unit. So let me tell you that from the total of individuals that were hospitalized, 1,300, 6% were admitted to an intensive care unit. Again, this is much more than the observation from the Chinese doctors, but it's something that remembers it's very similar what is seen in other European venues. As an epidemiologist, I have to tell you that always when we look at data, we want to pay attention to the age and sex distribution. In terms of this cohort of 10,504 individuals, there were more male than female patients. Exactly, there were 52.5 patients who were male, with a mean age of 58.2 years. As you can see, more patients were older than 50 than younger than 50. But if you pay attention, actually, there were more young women than young men in this cohort. Again, this is something that has been reported also in other European COVID-19 cohorts, not in China. Here you can find the results regarding baseline symptoms and comorbidities. For instance, the most frequent comorbidities were cardiovascular disease, especially arterial hypertension and heart disease, and diabetes. Regarding respiratory conditions, COPD was present in 6.4% of the COVID-19 patients. Asthma was with a very similar percentage with 7.2%, while, for instance, obstructive sleep apnea or bronchiectasis were present in only 2 and 1% respectively. As you can see in this figure, there are sex-dependent differences in comorbidities upon diagnosis, except for asthma. The frequency of all comorbidities was significantly higher in male than female COVID-19 patients, but as I tell you, not for asthma. If we pay attention to the symptoms upon the first contact with the medical system, here you have in this slide that the most frequent symptoms were high temperature, fever, then cough, and then dyspnea. But the maximum frequency was about in half of the patients. All these symptoms were less than 50% frequent in this cohort of individuals. Apart from these three, then there were crackles and crepitant rails, diarrhea, myalgia, rhonchus, and so on, until the symptoms that were of much less frequency. Here, in this slide, we explored whether the distribution of comorbidities and symptoms captured in the electronic health records upon diagnosis differ between those individuals that were not admitted in the intensive care unit or were admitted in the intensive care unit. Regarding comorbidities, diabetes, obesity, cardiovascular disease, heart disease, and renal dysfunction were more common among those patients who were admitted to the intensive care unit, all with a high statistical significance. On the other hand, regarding signs and symptoms, cough, fever, dyspnea, respiratory crackles, diarrhea, tachypnea, lymphopenia, and bronchus were found more frequently among ICU patients than in those not admitted to the ICU. Interestingly, again, regarding respiratory diseases, they were not more frequent in patients admitted to the intensive care unit than in the individuals admitted to the intensive care unit. There was no statistical significance of this comparison. Finally, these are the main results of this analysis, because we wanted to explore in a free scale analysis if there were some early predictors to identify which patients would require being admitted in an intensive care unit and the ones that were not requiring this. By using a machine learning data-driven algorithm, we identified that the combination of three easily available clinical variables, namely age, temperature, and respiratory frequency, was the most parsimonious, the most simple predictor of ICU admission among this group of COVID-19 patients. For this model, age and temperature were captured as continuous variables, whereas tachypnea was yes or no according to a frequency of 20 breaths per minute. The accuracy of this model of three symptoms only was very high, with an area under the curve that was ranging between 0.76 and 0.68. And on the one hand, those individuals who were younger than 58 years, 56 years, without tachypnea, and with a temperature less than 39 degrees, were associated with not being admitted to the intensive care unit. On the other hand, those individuals who were aged in between 40 and 70 years were likely to be admitted in the intensive care unit if they presented or with tachypnea or they delayed their visit to the emergency room after being seen in primary care. So this is the result that age, temperature, and tachypnea were the best three variables to identify which COVID-19 patients at baseline would require one of the most severe stages of the disease and would require to be admitted to the intensive care unit. As a final sensitivity analysis, and because we have to rule with the strobe guidance for observational research, but also when you try to identify a sensitivity and specificity test for diagnosis and for prognostic, such as this exercise, we perform according to tripod guidance a validation study. And we were selecting only 2 of the 5 provinces, Guadalajara and Ciudad Real, that they incorporated only 38% of the population of the region of the autonomous community of Castilla-La Mancha. And we use the population of these 2 provinces as the training set and eventually to replicate the results in the other 3 provinces, Toledo, Albacete, and here. And as you can see, the results were sustained. Again, the combination of age, temperature, and tachypnea, especially with or without the auscultation of respiratory crackles and rhonchus, were the most parsimonious model to identify admission to the intensive care unit. I stop here with the results and I pass again the baton to Dr. Medrano, who will go on with some methodological issues of this research. Thank you.
Sure. Yeah, thank you very much for that. It was very clear, very precise. We appreciate it. I'm not going to get too technical, definitely, mainly because I am also a medical doctor and I shouldn't and I cannot do it. But many people are in the last months getting interested in AI, actual AI applied to generating science. So no more science fiction anymore. Thank God. It's 2020 already. It's not 2015 anymore. And want to know a bit of how we do it. So that's a bit of what I want to tell the audience about. So the thing here is that in every point of care around the world, there's a lot of information that is accumulated every single day. We know this. This applies to primary care and to specialized care, to inpatient and outpatient. And from a few since a few years, we are already doing that in digital. It's not paper anymore. It's not handwritten anymore. And what that means is that we can take that information and we can give it to a computer so that it can apply algorithms to identify predictors, as we did with this first cut of results at the BigCOVIData study. But the thing is that there are a few problems if you want to do this, even if you're on digital already. The first problem is that the information is usually recorded in different systems that use different files and different ways of accumulating that information. And so that's why whatever you want to do with it, you need a system that is agnostic to the information system in place, and that can read PDF or TXT or HTML, basically an extension file. Otherwise, it's impossible. So that's one of the things that we are offering in this regard. We can do that. We can read basically any system as long as it's digital, as long as it's not paper. And the second thing, and it's the technically most challenging of all, is that the majority of what we write down is narrative, it's free text, it's linguistically human and complex. So, and when you go to any international database of information, call it RedCap, which is open, or some others offered by companies or by institutions, the problem they have is that they're just handling structured information. They're just using whatever is coded, whatever is codified, like sex, gender, maybe diagnose at discharge, maybe treatments, but that's around 20% of the information. What happens with signs, with symptoms, with other variables like secondary effects? What happens with all that? It's hidden, it's buried in free text. And this is where we come with this new technology that is called natural language processing, which is actually not new. It was used in other sectors and industries, but what we did is we specialized in reading clinical records. To be honest, there are other projects doing the same, but we are the first ones to be able to do it multi-centric, using information from different hospitals, as I said before, and even in different languages, even when in free text. So if it's a Western language, we can do it. And this is what we're doing now. And this is what took us basically to be able to automatically populate that database without a need to filling the variables one by one and case by case, which was more the original or traditional way of doing things. It's like saying that we're streaming the data now live from the hospitals. So that if you're wondering what kind of documents we read, we're basically reading whatever the doctors, the physicians are going to write down their daily practice. It can be a note, clinical note, can be a discharge report, can be the result of a test, of a radiology test, it can be a pathology test, but whatever is digital, we can extract it and we can now transform it into something that is structured, and then that, as I said, can now be read by a machine. Don't want to get too technical in the roots of how we do it, but the idea is that, as with any automatic system of all the AI that we're seeing ultimately appearing in our daily lives, the more it reads, the better it becomes. And that's the point. We've been doing this for 5 years. In the particular case of respiratory diseases, we have this Horizon 2020 backed project in 10 countries in German, English, French, and Spanish. So we've been, so to say, training the system in respiratory symptoms and issues for features for a few years, and now we were kind of more than ready to jump into COVID-19 quite fast, and that's probably the reason why we're giving results right now here, sitting down, even if technically what we're doing seems quite complex. One important thing is that you can prove how good you are. So there's always a random sampling by which you can tell what was the reliability, the accuracy of the system, and how it performed while transforming that unstructured text into something that is structured. We can do that by as I said, annotating a few variables and then checking how good the prediction of the machine was from the linguistic point of view. So that's going to be transparent, no black box at all, so we know. And one thing that is important is not to make it too techie and stop there. You have to do it clinical. You have to do it in a way that is actionable by actual physicians during a pandemic, like it's been the case right now in Latin America, for example. And so that in the moments where you have least time to dedicate it to doing research, but you need more research, as it was the case, you can continue working. And that's precisely what we did. We didn't have to stop because it's an automatic system. So we didn't have to request the time of doctors after seeing the patients to populate any CRF, because it was already done by the machine. Thank God we were connected to this system across Europe and North America, and that's what ultimately took us to do this first cut of results in the south of Spain, where we had the streaming of data every week, as Dr. Soriano already explained. one thing that is surely coming to the mind of everyone who is listening is, and what happens with privacy? Well, that is something that obviously needs to be in the core. It's not something that you just take care of when needed, but it needs to be in the center of such a system. Otherwise, we wouldn't have the trust of hospitals all around Europe and North America. More than 100, for example, in the south of Europe, in Spain. The reason basically is that we're not working on data that has any personal information. It's anonymized data. The second point, which is key, and the reason why it got approved by countless ethical committees and by information systems, both from public and private hospitals in both continents. As I said, the reason is that we're actually using synthetic patients. We're using data that doesn't really belong to individual citizens, but it's synthetic information that represents the actual information of the population, but doesn't belong to any individual itself. And by combining those, by doing it anonymized and synthetic, as you know, is not only legal according to HIPAA and GDPR, but also ethical to do what we're doing. Basically, clinical research is valid and ethical and legal. And I need to express this very clear because some people are not that clear about it without express informed consent. And that's how ultimately there are many Horizon 2020 projects, for example, today ongoing, which are using the information of millions of Europeans without specific signature. And that's thank God that's legal, and I would say that's a responsibility as a society to offer that information to the public and to be and to provide more intelligence to the healthcare system, as we saw that was that so important during this crisis. One more thing is not only the privacy of the patients, it's also the property of the data. Many hospitals are going to be worried about this. What happens with my data? Am I giving it to a company? What happens? That's very important. We don't believe in monopolies. We are going to a world where artificial intelligence is going to rule. It's going to have a lot of importance. If we allow companies to have monopolies over data, we're going to have a problem as humankind. We need to have federated systems where information keeps being under the control of the providers of healthcare. And that's what we do here. We don't take the data. We sign a contract that says that information doesn't belong to us, but it belongs to the hospitals. Whatever belongs to us is the possibility of helping hospitals reuse that information for scientific purposes. And that is key. That should be something that should be required by hospitals whenever contacting any provider of technology doing these approaches of NLP or big data or machine learning. Otherwise, we're going to have a problem as a society. So that should be guaranteed. And that's probably the reason why today we are proud to be a European Commission-backed company doing something that wasn't done in the world before. And in the countries we are showing until now, and now with COVID, in any other country that is listening, is attending, and wants to join, I want to remark the study is open right now, and you can simply write to us and say, I want to participate. We'll take care of how we do it, but we'd love to have you on board with this new technology and this new way of generating science, which is complementary to the traditional one. And with this, I'm finishing. Thank you for your time. And now, Dr. Soriano, we're ready to jump into the questions. There are a few of them. So this is what we're gonna do. If they're more clinical, they should be yours. And with pleasure, I will hand it to you. And if they are more technical, I can keep them myself, and we can discuss about them. So here, someone is saying, what are the next data points, like treatments, to be analyzed within the study?
Well, can you hear me?
Yes.
What are the next data points? Well, the initial concern that we had was with intensive care units, and especially here in Madrid, but also in anywhere in Spain, the March and April was Holocaust, and the intensive care units were saturated. The initial analysis was therefore on variables associated with intensive care unit. The next analysis that we are doing in this database of Castilla-La Mancha and eventually amplified within Spain and in the Europe and North America will be regarding mortality, and specifically because there will be more person time and there will be more complete data up to this very hard endpoint, death. So this will be the next analysis. And in particular, Dr. José Luis Izquierdo is very interested in the effect of treatments on mortality. So the respiratory treatments, the inhaled steroids, oral steroids, the antivirals, of course, chloroquine and hydroxychloroquine, but also other non-respiratory treatments that they were being tried during the crisis. Probably we should be able to get some results and to identify their effectiveness. And this is the next episode of this research.
Thank you. I guess this is probably for me, but maybe you can complement. It says, I am writing from a hospital outside Spain. How can we join the study? Okay, so yeah, the thing is, it doesn't really matter if you're in Spain or not. That doesn't count at all. We are an international project, and the study is now being followed or participated by hospitals in, for example, in the United Kingdom, a good group of them, and also in some other countries like Belgium, Switzerland, also North America. So no, I mean, there are no boundaries, there are no barriers in this regard. The only thing here is linguistic, because if you attended to the presentation, what we're doing is we're transforming language. So today we can do German, French, English, and Spanish languages, and Catalan, by the way. So that's where we can perform fast. We're also developing for being able to provide this same technology in Western languages, not Eastern languages for now. I want to be very clear about this. And so, yeah, the only thing you have to do is to write to us, easy to find in the website, and we'll take care of whatever needs to be done. A few tricks that need to be done with the IT department of your hospital or primary care center, so that the information can be analyzed properly.
And if I can add in this, especially, I mean, what this type of research is different to the usual that we have been conducting. And we all know in a clinical trial or in an epidemiological observational study, the different steps that we have to follow in the ethics committee or permissions within our department or within our hospital. When you are doing big data, and eventually what you are giving access is to electronic health records, not only on your own or not only of your department, but of an entire hospital or health center, of course, the level of scrutiny is much higher. But what Savana needs eventually is enthusiastic people. What they need is an ambassador. And especially because there are always hurdles. But what it is necessary is someone that establishes himself or herself as a bridge and that knocks at the door and is persistent. Persistence is a quality that specifically in science and particularly in big data is something that there will be always problems, and it is right to identify this and to solve them with data privacy and with anonymity. The good thing is that we already have tools to solve these problems and to jump these hurdles. But certainly what is necessary is in other hospitals and sometimes in other countries, these volunteer ambassadors to help to overcome these hurdles with enthusiasm.
Yeah. Thank you. So in future studies, I appreciate the question because that's a fact. We're going to proceed analyzing more information and publishing new papers. Will you include patients from clinical trials, so to say, analyzing treatments, including treatments that are still being analyzed in clinical trials? That's related to the previous question, but I think it's important.
Well, technically, yes, in the sense that the beauty of the big data technology is that everyone is included, and everyone with text in the electronic health record is included. So in theory, yes, individuals that are being included in a COVID-19 medication or in any other trial while being in that hospital or that clinical center, they will be included. But I have to tell you also that there are several layers of medical evidence, and still in terms of treatments, the clinical trial is evidence A. I'm not saying that big data is evidence B because it's big data, but the evidence A is the randomized clinical trial. And for this, they will give us a lot of information regarding efficacy and adverse events. But other types of evidence, like observational studies or big data technologies, they are agile, they can be reasonably quick responses, and they can be interpreted just to put the real world evidence in perspective with the results of future clinical trials. So in a way, it's a different layer of evidence, but it has to be integrated, and it does not substitute, but it complements the data from clinical trials.
Yeah. Thank you, John. I think it's important. I mean, to complement a bit on that, we are seeing how groups which are very excited about real world evidence and big data or even machine learning, we're seeing how they are starting to claim that somehow clinical trials are not needed because with this kind of information you have the same and it's faster. But come on, I mean, it's not true. It's not really true. Clinical trials are a unique tool that is needed to prove things in real life. We know that. Whoever has been in touch with actual clinical environments know how it works, and the opposite makes no sense. And it's not the purpose, and it shouldn't be. As you mentioned, real world data is complementary. And at the same time, yes, it's also fair to say that it offers things that traditional science cannot offer, because traditional science is about registering the information by hand, patient by patient, and variable by variable. And that's somehow a problem in the world in which we live, where things need to be instantaneous, and we have seen this through the crisis. So I would speak more about having both tools and using them properly whenever you need information that is very fine-tuned and very granular. For example, for proving a treatment, then you need a clinical trial, and then you need time and people, an army of people actually doing that, and that's good. We're not gonna exclude that, but sometimes you don't want to buy the CD in the store. You need the Spotify. You need a lot of information in streaming without limits, and that's what we call big data, and it also applies to clinical information. So if what you want is a Spotify because you're exploring, because you're generating new hypotheses, because you need a quick answer, because you're in the middle of a pandemic, then maybe you should consider also using real world data, right? And that's probably where we're heading. So okay, this is interesting. Has prone position been studied as a method for conscious patients that reduces or avoids ICU admission? You want to go with that?
Well, I mean, the changing the back on top of the patients in the intensive care unit is considered mechanism that improves the oxygenation of these patients. And this is something that without a clinical trial, the doctors and the nurses have been experimenting, and they have found that this was useful. However, in our analysis, we have not explored this. Actually, I don't think that the terms pronation or prone were investigated initially, but this is something that definitely we could find for the future. We could explore it.
Yeah, sure. I guess this is more for me, but maybe you can also help me with it. It says, can other researchers participate in the publications, I guess, itself as authors? So what I need to say here is that, of course, yes. I mean, you're very invited. What we are looking for is authors. What we want is researchers, clinical researchers that are actually seeing the patients, treating the patients, or or studying them from the epidemiological point of view, and who want to participate in a general study that will consider information from all the points of care that we are able to gather together. And from there, we will be very keen to leave that to the authors that want to do individual explorations of that information.
I mean, the authorship in research is something that is already established, and we just abide to this. For instance, in this preprint, we have Dr. Izquierdo, Dr. Ancochea, myself, but an entire group of researchers in Savana that include biostatisticians, nurses, linguists, engineers, software developers. So, and the key always is the Vancouver rules. So if you are participating in collecting data or in analyzing data, and you get hypotheses, you participate in the drafting, and you accept the final version, it is not only right, but it's an obligation to have authors. So in this, we have experience with Savana, with the PAGE study in asthma, or with the big COPD data study with national and international authors. The rule is always to be flexible, and certainly if you deliver and you participate, you not only have the right, but as I said, it is compulsory that individuals that fulfill the Vancouver rules, they should be authors.
So thank you. Do the machine learning models treat the information collected as a diagnosis in the same way as the one included as for example, as a clinical note? I think it's a very good question. I can answer that. And of course not. I mean, let's call it the algorithm to make it simple. The analysis of information is looking for the outcomes, and then for the variables that are influencing those outcomes, as in any predictive model, as it would happen in a regression, for example. But maybe the difference, to explain it somehow, is that here the computer is somehow deciding the weight that is going to be given to every variable, contrary to what happens in a non-big data approach or non-machine learning approach, where the human, the expert, is deciding the weight of the variables, and then you are generating the model and you're validating it. So we're ending at the same point, the validation of the scale of the risk score, but the means by which we get there is basically that the weighting of the variables is going to be decided by an automatic system, so to say.
And if I can add on this, Nacho, I mean, as an epidemiologist, that all my life we have been told, first anticipate what could be the result and then do the experiment. This way of working with free scale, that sometimes you don't have a hypothesis and you leave the machine learning tools not only to identify the values, but even in giving you the thresholds, is something very attractive. And We take it for granted because it seems obvious. But for instance, in this study in Castilla-La Mancha, to identify the factors associated with admission to intensive care unit, the result was a temperature of 39 and higher and an age of 57 or higher years. But this was given by the machine. So the algorithm was first extracting for the clinical notes of a doctor in primary care or a resident or adjunct professor in a hospital, in a ward, in the emergency room notes, that they typed the temperature and they typed the age. So the machine was identifying these thresholds. As I said, for tachypnea, the standard always is 20 breaths per minute. But for age 57 and for temperature, the 39 Celsius, these were identified by the machine, so by the algorithm. So this is something really very attractive. And eventually, I'm very optimistic that when we have a bigger sample size with more follow-up, the outcome prediction of death due to COVID-19, this is something that we could get surprises and identify variables that are beyond our current knowledge, and this will be something surprising.
Yeah, especially in a disease where we don't know many things, right? So it's even easier to find new correlations that are simply not known.
Well, it seems that we have been living all our lives with COVID-19 and with virus, but this is only 5 months. We only have 5 months experience. And of course, no one is going to read the 20,000 papers, but at least some of you will read this paper.
Yeah, so if you haven't been in touch with machine learning previously, this is a big opportunity. You're probably already seeing how around yourself it's growing. And I would like to invite you to investigate and to check how this is a growing trend. The fact that machines looking at data, and I'm saying this as a person that is also new in this field. I'm a clinical neurologist. I've done things the traditional way of all my life, but we can see how really machines can get to find associations or correlations that are interesting to explore at least, and that we hadn't thought of, and that's a new opportunity of doing things. The earlier, what I've learned is that many mistakes are to be made. We're entering a new field of epistemology in this case. So the earlier we do it, the earlier we start failing, the earlier we'll learn these new methodologies. And that's why I would like to invite you to explore this. And if you're already into machine learning and you know exactly what we're talking about, and you're into this field and have some research, well, this is an actual tangible opportunity of doing it with information that already exists and that you don't need to capture again. That's why we're so excited to be offering this. So let's go with the last question. Are there problems with the healthcare ethics committees approvals in some countries in Europe in terms of data protection? Do they accept data anonymization? You want me to proceed?
The short answer is yes, right? There are problems with the ethics committee and with approvals and with anonymization. The sad thing is that at least in the European Union, even if we have a common law, the standards for acceptance of studies like this are very variable. And what, for instance, Dr. Izquierdo was very quick in getting the acceptance of the ethics committee from Castilla-La Mancha for this study. For other centers or for some countries, the threshold is very different. And this is one of the fights of many people in the organization within Savana, that they have to be persistent. And it is surprising that in the 21st century, when in your Facebook or in your Instagram, you give very personal details, that things that eventually could help clinical research, sometimes it is one hospital giving the yes and the next hospital giving the name. And the law is identical within a country, within a city, but the variability of the response is high.
Yeah, so I would like to say that on that reason and logic is on our side. That's important. We have to know this. We have to know that reusing clinical information from medical records, if anonymized and for clinical research, even or despite non-existing informed consent, is not only legal and compliant with GDPR and HIPAA in the US, but also ethical. And what is probably unethical is not to do it. And we have to know this, and we have to be very clear, because in the majority of the cases, if we know this and we are reassured when stating it in front of the IT departments or the managers of the hospitals, it's usually when it works. So altogether, our experience is good. We have to say that we got approved by the majority of the ethical committees to which we apply. Fair enough to say that there are places where simply politics apply, not laws, and that's why sometimes it doesn't go as fast as we would like. But in the majority of the countries where we were developing this, it's working, and it's covered by GDPR in Europe, answering the question. So I would encourage you to contact us. You can do that at info at Savana Med, Savana as it sounds, and med from medical, savanamed.com. And we'll take care of it. We'll take care of your center, your point of care, joining this study. And by the way, with the same technological effort, future studies that we will keep performing. So I want to thank you for your time, and I want to especially thank Dr. Soriano for his precision and his clarity explaining this first stage, this first cut of results of the study. I really appreciate your time and your effort with this.
It was a pleasure. Thank you.
Thank you. Have a good one, a good day, and stay safe.